thank you very much for joining us today. So if we get started, first of all, I should introduce myself. You may have seen me before on webinars that I've attended previously. I've been lurking around in the NELA project team for a few years now as a nurse fellow, but I've recently taken on the role of NELA nurse and AHP lead within the project team. My role is brand new. It's been implemented from March this year, and really born out of a recognition that whilst NELA focuses very heavily on the medical aspects of emergency laparotomy care, and we've seen lots of improvement over the lifetime of the audit, there is a bigger picture going on there in the background, and nurses and AHPs working across the breadth of the emergency laparotomy pathway are absolutely integral to getting these patients to the point of surgery, through their surgery, and helping them to recover afterwards. So the aim for my role really is to support nurses and AHPs working in this setting, to raise the profile of the importance of our roles across all aspects of emergency laparotomy care, and to try and standardise the care that is delivered to our emergency laparotomy patients. For a couple of years now, we've had an emergency laparotomy MDT network on the go, and some of the colleagues of mine that you're going to meet this afternoon, I met them through this network. We meet quarterly. It's really a place that we come, get support from colleagues, some clinical supervision. We invite speakers to join us. So previously we've had members of the MDT or people that have got research projects going on around emergency laparotomy care. So if anyone on the webinar today is interested in joining that, please get in touch. You're more than welcome. We have a mixture of nurses, AHPs, surgical care practitioners, and physician associates. So yeah, it'd be great to hear from you. Just before we kick off with the speakers, again, just to emphasise the importance of nurses and AHPs across the whole of the emergency laparotomy pathway. So if we look at these pinch points here, this diagram's from one of the yearly reports, thinking about where nurses particularly are present on this pathway, they're everywhere, all across it. So we really are a fundamental part of the patient's journey. If I asked you to think of some significant areas where nursing input is of great value to patients, these probably would be the ones that spring to mind. So particularly thinking around stoma care. Without the stoma nurses, patients would struggle to be able to manage their stoma and get back home and be able to manage their own care. Particularly thinking about the older patients who are undergoing emergency laparotomy, of which we know half all patients are over the age of 65, greater risk of delirium and deconditioning. So if we're not there picking up on the early signs, encouraging them out of bed and getting them to eat and drink, can run into all sorts of problems. And particularly thinking about comprehensive geriatric assessment, so that is a multidisciplinary process with multi-domains, and nurses and AHPs feed into that significantly. Just drawing from some of the literature that's out there, so particularly around patient experience, there's been only a handful of studies really that have looked at the experience of undergoing emergency laparotomy from the patient's perspective, but the themes that come out from all of the papers are very similar. So people, when they're in hospital and undergoing this type of surgery, want to feel cared for, they want ready access to information, and they want staff to be able to answer their questions when they have them. They really value continuity of care, so thinking about that pathway and who's present across the pathway, and they value their care being managed with a holistic approach, so not just thinking about the physiology of what's been done to them, but can they get on their feet, are they eating and drinking, how has this affected them emotionally. So again, more evidence to support the need for good nursing and AHP care for these patients. We know that across the pathway there are particular pinch points where perhaps things are not going, don't move as quickly as we would like them to, but there's also areas where we're not quite sure what happens. I think we know there's delays at the front end of the pathway. We don't really know at this point what happens towards the end of the pathway. We know outcomes are poor in the first 30, 90 days following surgery, but what's going on at that time? Hopefully my colleagues today will be able to tell you about how their roles are focused on these different areas of the pathway and the benefits that they bring into patients. In terms of emergency laparotomy specialist nurses, I know through working with them within the network what a valuable role they have and the impact they do make for patients. But unfortunately, it's not well known or well recognised at the moment. So you can see on the map, there are much less pin drops there than I would like there to be. This is where we know we have colleagues working in these types of roles across the UK at the moment. The evidence is not yet there on a large scale to support the implementation of these roles, but some provisional work by colleagues up in Glasgow has shown that with the introduction of an emergency laparotomy specialist nurse, length of stay was reduced. And Maggie Clark, who is the LSERV nurse up there, has done a fantastic job of developing a multidisciplinary team pathway for these patients. So my vision as the nurse and AHP lead would that we can support other sites to implement these types of roles, and I'd like to see many more pin drops on the map within the next couple of years. So without further ado, let me introduce you to the first of my colleagues, who is Guy Arries. Guy, you'd like to share your screen and video?
Hello, just sharing now. Is that coming up on the screen there?
Not yet.
Oh, let's have a little look.
Yeah, there we go. Thanks,
Is
Guy.
that on?
Indeed, over to you. Thank you.
Yeah, thank you. So hi, I'm Guy. I'm from Northumbria Healthcare, which is in the northeast of England, if you can't tell by the accent. I'm the NELA specialist nurse practitioner. I guess it's worth introducing the sort of NELA team that works within my trust, as when I joined the team, there was a well-established team who had special interests already within each part of the pathway, and I've kind of had to squeeze into that and find out where I can sort of improve the patient experience the most. I tend to focus mainly on the front door, patients arriving to E&Es and surgical assessment units with an acute abdomen, and I draw my sort of accountability and supervision and what I'm doing in practice throughout these leads. So yeah, if there was any issues, so to speak, one of these would be feeding back and giving supervision. Because we have such active leads, it means I can contact these for any QI, and they all know the sort of role in the NELA pathway that's going on within Northumbria. So I'm not going to mention all of these because I am here to talk about the front of house pathway, but sometimes the sort of acute abdomens that are possibly at risk of having a NELA pathology, some days that might be a lot, that keeps us very, very busy, and then other days there might not be as many. So have other areas that we do to keep us busy. So essentially, in a nutshell, I try to pick them up at the front door and be a continuous face for that patient throughout the journey. So I would see them, sort them, get them to theatre, catch up with them throughout the journey, just familiar face, how you doing, information leaflets, any questions, and yeah, we do the database from a quality improvement point of view, make sure that it's quality assured, that all the information in there is accurate. When I first started the role, some of our numbers were a bit array, and through audit, seeing that actually it's not that we were poor in certain areas, it's just that the data that was getting in that was perhaps a bit poor. Yeah, we also grant all the new sort of surgeons, access, and yeah, find out any quality improvement that we need to do, and then educate the frontline staff who need to be delivering that. Also provide feedback to frontline staff of what worked well, what could perhaps have worked better. There's always junior doctors and staff and such looking for QI work, and they often come to me from a NELA point of view if that's where their interests are, and I can help them pull the data and sort of see if where perhaps we could look at from there. But essentially, from a front door point of view, I sit in our surgical assessment unit. That's because I'm just one man, and I need to base myself somewhere. At Northumbria, pretty much all abdominal pains who present to emergency services are streamed around to our surgical assessment unit, whether it's appropriate or not. We do have some exclusion criteria, so there is a small percent in daylight hours that still go through A&E. They're either really sick or perhaps presenting with surgical inappropriate things like obs and gynae issues or clearly gastro conditions. But at the forefront of that, I will be on the assessment unit at my computer with multiple screens, like this gentleman in the bottom left there, looking for that needle in a haystack. Reason we call it needle in a haystack. Up at Northumbria, I get the number of patients who present with acute abdomen through our A&E departments and our surgical assessments. Probably looking at about 650 in each department, and our assessment units are only open in daylight hours, sort of 8 o'clock in the morning till 9 o'clock at night. Stop taking referrals at about 6, 7 o'clock, depending on the pressures there. So I would be on the assessment unit, looking at the screens, reading the triages that the triaging nurses from the assessment unit and ED are doing. I'll search those triages, looking for anything I deem as an at-risk patient. Look for keywords, which I'll go into on the next slide of, ooh, that actually sounds like it could have a serious problem there, and perhaps don't think they should be prioritized to an 8-hour wait in the waiting room. So I'll just pick them up, see them, work them up, and refer where is appropriate. So essentially my remit of what I see is not NELA specific, it's acute abdomen specific. So maybe referred to as an acute abdomen responder or an acute abdominal outreach practitioner. I do often work with the other outreach practitioners in the really sick patients. Like I said at the first slide, because we have leads in critical care and things, I know and work well with them. So the nitty gritty of what I do is I look for these red flags that I've mentioned here at the top. Those, I know it's difficult to say if it's NELA specific or not, but it's certainly too much referral criteria to put on overstretched services such as surgeons who are very busy, surgical registrars who are getting referrals from every abdominal pathology, not just NELA ones. So I'm kind of a person who's supernumerary, not included in the numbers, can slide away and just take these patients out of the queue. So look at the triage. Are they at risk? See them, resuscitate them, escalate where is necessary. So we have this sort of protocol at Northumbria where if we suspect that somebody's got a tender, small or large bowel obstruction, any ischemia, perforation, that where they're unstable or a sort of strangulated hernia, then we can just refer to the surgeons directly, and we should be aiming for an hour to review. Now, if patients are being prioritised as P4, putting an 8-hour queue in a waiting room, for example, then that's not going to help with our targets to theatre. So I would go in, resuscitate and escalate if I thought it was a NELA red. If I didn't think it was a NELA red, which is terminology that we've come up with in Northumbria, if I didn't think it was NELA red, I would go down the diagnostic line, do the referrals to the relevant specialities and request the relevant imaging, prescribe, painkillers, anti-sickness, just keeping the patient comfortable throughout that. And then if the patient was to be a surgical pathology that would fall into the NELA inclusion, I would make them referrals to the surgeons and hopefully have it tied up in a nice little neat bow for them. So the referrals that they're receiving are sort of appropriate and they don't need to go into the little specifics that take time. So in scenarios where acute patients are confirmed to have a NELA type of pathology that may go onto the MLAP or NOLAP database, I would calculate those risk scores and add them to the database. I do the risk scores like delirium scores, frailty scores, anticholinergic burden scores for medications, AKI sort of risk factor things, and essentially, so if I was to speak with the surgeons, so say I'm in A&E, for example, I've got a patient septic, CT confirmed perforation, I'd say, you know, this is the risk score, this is how frail they are, this is how active they are in terms of who performance, and yeah, could you come down and see them, and hopefully that gives them a lot of important information that they need in those serious discussions with the patient. So from a nursing point of view, what that does for the patient, well, it puts them in a position where I could pre-warn a patient of, you know, I was a bit worried about you when I seen you. We found some concerning features on a scan perhaps, and we need to get surgeons here for some serious conversations, and hopefully that can prepare the patient to think of any questions they may want to ask, or get the relevant people in, like that next of kin or carers, or any support that they may need. Can also provide information leaflets so they can think of any questions, or signpost them to online resources. Would also accompany those surgical reviews and decision makings, and, you know, do the documentations and the time consuming things that really, you know, take up a lot of time but are so important when we're doing these auditable points, and then provide that sort of nursing care of, you know, staying with the patient after and providing that emotional support and just answering any questions where I can. I would also, you know, just make sure that all of the recommendations and guidelines that are set out in the sort of ERAS, Royal College of Surgeons, NELA recommendations are just getting done, such as variable rate insulin infusions and erratic glucose and electrolyte replacements and stoma sighting. So that's a new thing that we're doing. Shadowed the stoma nurses, work with them well, attended a lot of stoma sighting courses, and if they're not available, then at least I've got some clue on counselling them and marking out the creases and, you know, where they may or may not want it. But yeah, I'm supernumerary. I have the time without the clinical pressures to, you know, take the blood tests, group and saves, insert NGs, catheters, cannulas, do the checklist and getting them prepared and optimized for theatre. All of which have historically been done by the clinical teams, but as pressures continue to increase, I can just focus on that. And then, yeah, just think of any questions and I'll answer those at the end. But that's kind of the front of house things in a nutshell.
Absolutely fantastic. Thank you so much, Guy, for telling us about your role. It's always really inspiring when I hear you talk. Next, I would like to invite Amie, who is joining us from Leeds, and Amie and a colleague have a fantastic service there, particularly for patients being discharged for hospital. So Amie, if you want to share your slides and video.
Hi everybody. Just try and get this into a slideshow for you. Oh. There we go. There we go, we got there. So hi everybody, my name's Amie and I currently work at St James's Hospital for the Leeds Teaching Hospital Trust. My current role is a NELA coordinator, and I also have a colleague, Glenn Marshall, who's a NELA practitioner. Both nurse backgrounds, both surgical backgrounds, colorectal and acute backgrounds as well. So our team focuses mainly post-operative care, so that's what we're employed as, post-operative practitioners. So although we are involved with some of the front door things, our main focus is recovering patients after emergency laparotomies. So I've just kind of listed a couple of things that we tend to focus on just to share an outlook of our role really over here at Leeds. So it's just a lot of your clinical things, as Guy said, taking that pressure off other individuals, especially on the wards. So we tend to do a lot of dressing changes, ensuring clips are removed at certain times, advising staff on the ward, helping with wounds, complex wounds. We also tend to liaise and refer to tissue viability, medical photography, etc. We also work really closely with our colorectal nursing team, who are our stoma nurses. They tend to review patients Mondays, Wednesdays, and Fridays. So myself and Glenn will support patients in between these visits, which helps give them a lot more confidence, help them gain competency a lot quicker, and again reduces bed stays, and also supports the staff on the ward taking that role away from them initially. So we can help with that. A lot of our patients can sometimes get peristomal skin conditions if they've got high output stomas, etc. So myself and Glenn will help to manage that. We'll liaise with the stoma teams, give advice on medications, such as your loperamide, etc., and also provide supplies for stomas in between these visits. We have both been on a acute stoma sighting course, so we offer that service as well. Although we're not out of hours, and the stoma nurses are around, if they're stuck in clinic, we can go down to the wards and support the surgeons with the sighting. We tend to do a lot of speaking, sharing our role, educating nurses on the wards to ensure that our emergency laparotomy patients are getting the best care and support. We also do a lot of educating to the new junior doctors coming through, even the surgical registrars, and just updating everybody on the latest NELA information, really. We have done quite a few study days to support our nurses, most recently doing one for our colorectal wards. We got quite some feedback on that as well, so we will be doing more of them. I think the main thing that I do love about this job is, coming from an acute ward background, is actually spending as much time with that patient as we need to. And myself and Glenn can share out that role and go off and do other bits and bobs in between. But I think after an emergency laparotomy, you know, the outcomes, patients wake up and they have stomas that they weren't expecting, and it can be a very traumatic experience. So actually having that time to sit with patients and also families, just to discuss it and support and reassure, I think that's probably one of the great things about this role over at Leeds. We also have a super supportive geriatrician lead, who we attend ward round with twice a week to review our patients who are frail, our patients who are over 65. And it's great to share knowledge between ourselves from a geriatrician point and then from surgical background as well. And we'll review them patients twice a week. Again, this improves NELA data, but also improves patient outcomes. We also tend to arrange MDTs. So I think at one point we were doing weekly MDTs with the dietitians, just to ensure that they're aware of certain patients and they're on their caseload. Really, really close relationship with all our physios, nutrition team, etc. And we have, although over at Leeds we are an acute service, we still keep patients on our radar. So if we notice a patient's been in for quite a long time, we'll then see them patients and get involved and see if we can push any discharge plans, and we'll also get the geriatrician input for them as well. So there's always that support there if they need us. We also provide written information of the care pathway. We give out leaflets, we give out contact cards, etc. We also have a helpline for our discharge patients. So when a patient's discharged, we do give them a contact number for our office. Obviously, it is only a Monday to Friday service, but they can leave us a voicemail over the weekend or out of hours if needed. just to give support and advice over the phone. We have actually admitted patients from this helpline. We tend to get them into our ambulatory clinic or SAU if we think that they need to come back in. And a lot of the time they can come and be seen, and they can be without even admission, and they can just go straight home from there. So that avoids ED admissions, waiting times. And we facilitate that through either our emergency general surgical consultants or our surgical regis on call. I also run a face-to-face and telephone clinic. It is supported by our emergency general surgeons. It is based down in their clinic, so if I do need any advice or support, then they will always step in and give me a hand. This frees up actual medical appointments, and also it's a continuity of care because they've seen me initially post-op, and I'll always make them aware that they will be seeing me in clinic as well. Just going back to things on the ward, so we facilitate quite a lot of changes, so just to ensure that that patient gets the earliest recovery, so taking all the tubes out, NG tubes, taking catheters out, lines, ensuring that PCASs are down so we can get patients up and running as quickly as possible so that they can progress within daytime hours. We also work closely with our research team, get involved with clinical trials, help support them, help get patients on board with that as well. We've started, well, we've been doing it for quite a while now, getting patient feedback, which I will show you in a second, by using a QR code. And also we've been gaining some feedback on our emergency laparotomy booklet, because that's fairly new, a new thing that we've brought out. And again, database management's a huge part of it. We do quite a lot of chasing up with the surgical teams and the anaesthetic teams, but myself and Glenn also input the NELA data for our trust. We're keeping the trust up to date with data, reports, and tariffs such as the BPT. And I think this is lastly the point that I will stop waddling on about, prescribing. So I'm currently doing the non-medical prescribing course. This will help facilitate ward rounds with my geriatrician, and also facilitate everybody else's ward round. So getting, for instance, PCASs changed to oral analgesia a lot quicker. A lot of the time, sometimes after a surgical ward round, this might not finish until the afternoon. Whereas if I have the prescribing qualification, I'll be able to get things like this done in the morning, antiemetics, and things like that. And then I just thought I'd finish off on a high. Just popped a bit of patient feedback that myself and Glenn have received. I won't read them out specifically, but I can just let you have a little look at them. Number 10 on there is the best score we can get, so just in case you're wondering. But that's everything from Leeds.
Oh, thank you, Amie. Fantastic. I'm not surprised that that feedback is as good as it is, because it sounds like the service that you deliver is really beneficial for patients, and really good for us to be able to see how you can impact sort of the discharge end of the pathway, and speed things up for patients. So just a reminder to everybody who's joined us, if you do have questions for any of the speakers, pop them in the Q&A box at the bottom of the screen, and we'll have plenty of time for questions after our final speaker. Very happy to introduce Nick. He is a NELA nurse practitioner from Derriford Hospital down in the southwest, and I know he's done some brilliant work, particularly in terms of improving the data collection at his trust and making sure that they are achieving the best practice tariff. So I'm sure he's going to tell us all about that now. Over to you, Nick, if you want to share your slides.
Hello, everyone. Can you see my screen?
Can't see your slides. You're sharing your screen, but not your slides currently. Yes.
Better now?
Yeah, if you want to start your slideshow.
Lovely. Good afternoon, everyone. My name is Nick Preda. I'm the NELA nurse, Derriford Hospital in Plymouth. My story. My NELA role started back in November 2021, and initially the post was a secondment for 6 months, but after showing the data collection discrepancy, the post was made permanent after a month. Basically, I spent probably a couple of weeks' time looking at the missed cases that were not added into the NELA database, and was the best, obviously, opportunity to convince the board that this role is very important and it needs to be made permanent. As obviously, when you start a new role, you don't know much about it. So I would like to say many thanks to Dr. Caroline Johnston and the Royal College of Anaesthesists YouTube channel, because by looking at the videos that are on the YouTube channel, I was able to understand what can I do in order to do something about my role and to do something about the patient care. Again, I'm not going to go through the figures because they're all online. So the first thing I've done once I've started my role, after getting familiarized with the NELA role, was to get in touch with the theater team and with the anesthetic team and the surgical team. My background is surgery, so I was lucky because I knew all the surgeons. So it was just a simple conversation to reintroduce myself with my new role and that I need their support. So after discussing with all the colleagues, I thought it was a good idea to actually have a sort of a perioperative checklist for emergency surgery. So the way I've been doing this, when the patients are booked for theater, I'll go to the patient and I will go through all this checklist to make sure we reduce delays and we get the patients quicker into theater. If there's any problems with the blood tests or the ECG or any other problems, I will get the anesthetic team on board or surgical team to help and optimize the patient. If the patient will require a stoma, I will get in touch with the stoma nurses, and also I will be around to encourage the surgical team and anesthetic team to make sure the NELA score is calculated and documented. And the other thing I will start is just adding the data to the database, because you have in front of you all the documents and all the information. It's online nowadays. On the previous website, and after looking at the YouTube channel from Royal College of Anaesthesists, it was very easy to create some posters, and this was a very good type of information that I was able to publish into the anesthetic room, surgical room, also to present at the CME. And one of the important information that I've seen that was in our trust. This is a generic poster. I tried to exclude the hospital and just left in there the date, sorry. I've noticed the points on number 7, patients that are over 80 or over 60 and frail assessed by care of the elderly. So after a few discussion with one of the colorectal registrar, we thought on some ideas, and obviously the over 50% of the population, it's over 65, and sometimes they're frail. So what we've done from there, we managed to get in touch with the healthcare of the elderly, and we had a few meetings. And what I also done, I went to Cardiff and visited the Cardiff Hospital and spent some hours with the consultant geriatrician running the POPs project in Cardiff. Obviously, from there, in October 2022, we decided to start a NELA frailty pilot. So basically, if the patient is over 65 with a CFS over 5 or over 80, automatically a referral will be done into CR, and the patient will be reviewed by a colleague of the healthcare of the elderly team. This is also an opportunity to do some teaching sessions for the junior doctors. I'm joining the doctor injunction every 4 months, and I talk to them about the importance of NELA and the importance of frailty, and the advices about what they need to do. Our initial data, as you can see, from December 21 to October 22, it was obviously 0%. Once we start the trial, I was doing the referral. The colleague from geriatrician team, either registrar or consultant, was we're both seeing the patient and reviewing the patient, and if we had any major changes, we will be communicating with the surgical team. The results after some months, they are very good, and we managed to go from 0% to 47% on the first trimester, and up to 84%, without knowing that this will be the one of the new criteria to achieve best practice tariff. So we've done the most important work 6 months in advance to have this implemented, because the new criteria of best practice tariff was introduced in April 2023. So probably a lot of you are aware of the criteria, so I'm not going to go through them. So surprisingly, after the first report has come up, we realized that we'd met the first time the best practice tariff after 10 years of being working into NELA. Also, obviously, if you achieve something, it's good to share with your colleagues, and obviously I was able to publish my story into our Friday 5 journal that we have every week, and it was a way to make people aware that there's a NELA nurse around, and I'm happy to help. What we've done in the meantime, we also managed to get in touch with dietitians, physiotherapists, pain team, anesthetic team, and we created a post-laparotomy surgery. So every time I go to see the patient, I'll have either the QR code with me or the paper form that will cover information about almost everything that the patient requires, from sleeping, physio, exercises, pain, wound care, and all the information that is necessary. I also do block training days with the nursing staff on the wards and the student nurses every month, and I've been promoting over the last 3 years on the surgical wards the new colleagues to have a day dedicated to shadow me, so they can go to theater, they can watch a procedure, they can understand better how a laparotomy is performed, how the LAI is introduced, and how it should be removed, drains, and wound care. I thought it would be a good idea also to ask some opinions from my colleagues. So I've sent around to my colleagues a feedback survey, and some of the answers were very good. And as you can see in there, they're thinking that obviously my role is as a care coordinator, streamlining the patient pathway, smooth one-stop point of contact, nothing gets forgotten, and so on. As you can see, majority of them were from surgery, and the other ones were from anesthetics. What's next? After last year, when I was participating in one of the research study that was looking at the outcomes after having emergency laparotomy, that was the Emerald study. My plan is to get some more feedback, get a feedback survey from the patient, and to introduce follow-up clinics that will look at outcomes at 3 to 6 months after emergency laparotomy. Many thanks, and I would like to say a massive thank you to Angeline and to all the other colleagues that have helped me throughout the journey. Was not easy, and we actually created a very big network of NELA nurses around, and we, like Angeline has said, we are having the regular meetings, and we talk and we share ideas. Thank you.
Thank you, Nick. Brilliant to hear about all the work you've been doing. If you keep your video on, and I ask Guy and Amie to also join us with video so that we can start to answer some of the questions that you might have. So yeah, please do pop questions in the Q&A box. Start off, we have one for you, Amie. At what point do you meet the patients? Is it prior to surgery?
I mean, sometimes if we hear about these patients quick enough, we can get to them beforehand, and that's when we tend to provide the information, give out patient leaflets, but more so we do tend to meet them post-op at the earliest opportunity that we can. We don't actually see patients on intensive care. We do wait until they step down to the wards, because that's when we feel we can, there's lots of teams up in ICU, and on the ward, we want to get them up and recovering. So that's when we'll first see them. But first day post-op, if we can, if myself or Glenn are around, and then we'll see them often throughout the week, maybe 2 or 3 times.
And I think the patients value that, being able to see the same person more than once, don't they? And
absolutely, yeah.
Having that question that they forgot to ask you, but they know you're coming back and they can ask it you next time.
Yeah, and as well, they see the for our older patients, they see the geriatrician twice a week, but they'll also see me and Glenn there as well, with us. So they know the NELA team, they know who they're expecting to see, and they know that we're there to support them with anything they need.
Fantastic, thank you. Nick, who takes ownership for completing the fantastic pre-op form that you developed? And did you find that the staff were receptive to using the forms when you introduced them?
As everything in life, nothing is easy. It's difficult to make changes easily, but by doing consistently this type of teaching to the junior doctors, presentations at the CME every 3 months, by getting the student nurses or the new qualified nurses to spend the day with me. Also, by doing this was a way to actually take some of the pressure on the wards, because sometimes you just start the shift on SAU and you have the theater team on your back, you just take a handover and they say, oh, is the patient ready? Just about to go for a laparotomy. So if I'm here, I'll take that away from them. But again, it's a consistent work. That's why we do the monthly block training for the nursing staff on SAU, and we always I always talk to them about the importance of making sure the patient is ready, because the theater time is very precious, because you might have someone in ED waiting for this ischemic bowel and you can't get into theater because you had to spend half an hour to do an ECG down on recovery area because it was not done prior to surgery. Yeah, it's a constant teaching and learning for everyone.
Yeah, definitely. I think sometimes a form, it's another form, but you do, when it's the right kind of form,
it was more to show awareness that I'm around, and just to remember the colleagues what needs doing, not to the nursing staff only, also to the colleague, to the doctor colleagues.
Yeah,
because sometimes they spend 4 months in surgery. By the time they try to adapt, they move to a different specialty. So that's why I'm trying to be around at the beginning of their junior induction, and when new colleagues are starting their roles in the surgical wards.
Yeah, always like a crib sheet. Okay, here's a little maybe contentious question. What band of nurse do you think is best placed to take on the NELA lead role? So we've chatted about banding of NELA nurses in our meetings, I know previously. So if I was to weigh in here, I would say that you've heard the work that these 3 guys are doing. It's really advanced level practice for a nurse. So I would say the lead role should be a band 7 nurse, or AHP. So we're not limiting this just to nurses. Of course, we know we've got AHP colleagues that might be working in similar type roles. So I don't know whether you guys would agree that you need a band 7 nurse at least as the lead, and then definitely a mix of different practitioners can work as part of the team. And I know that some sites across the UK have got band 3 practitioners that take the lead on getting patients up and moving, but you definitely need that senior level oversight to make sure that everything that's happening is happening in the right way. Would anyone want to add anything to that?
Yeah, you're absolutely right. The NELA role job description is on the website, and for me personally, it took me probably about 1 year to get to the appropriate band 7 position. But all has been done by working hard continuously and showing the difference and showing how important it is to have someone basically to run the show.
Absolutely. Sort of a follow-on question from that, from Svetlana. If we invest in nurse NELA lead, are we still going to have NELA lead surgical consultant or anaesthetist? So I think my answer to that question would be a nurse NELA lead is not substituting for any other role. This is a really important aspect of emergency laparotomy care that needs to come as a combined effort. So it's a multidisciplinary approach to care for these patients. So no, nurse NELA lead doesn't replace anyone. They complement and add extra points for consideration and extra aspects of care that need to be considered. Are any of you three part of your local NELA lead team? Guy, do you get involved in that?
Yes, I attend all the NELA meetings with all the leads, and yeah, it's essentially, like I say, I'm accountable to those leads. So in terms of does the nurse role take over those sort of leads? Absolutely not. I guess on the front of nursing staff, then it offers a good opportunity for you to go in and do, like Nick was saying, the teaching to the nursing staff and such. So you do take on a bit of a nursing lead, but that's just because you understand how the accountability of a nurse works in terms of from triage to the ward nurse to the discharge. So, for example, I wouldn't go to a surgical directorate meeting and tell over 40 surgeons that they should be practicing in this way, because that's what that works. It's similar. I wouldn't go to critical care and say you need to be, intubating these patients in this type of way. I think it's very important that you have leads from every speciality and you implement the QIs that they're putting out there and get involved and feed that to the nursing. But yeah, I attend all the meetings and all the patient safety meetings, all the deteriorating patient board meetings, because we've got NELA as a at-risk group, specialist group, deteriorating patient group. So lots of meetings.
It brings a different perspective though, doesn't it? So like I said at the beginning of the webinar, so NELA has focused rightly on some of the medical aspects of care for this group of patients, but looking more broadly, it is a multidisciplinary team effort, and we do need them different voices around the table because we all see things slightly differently and we might identify problems in different ways. Another tricky question, so from an anonymous attendee, how in this time of financial constraints did you get funding from the trust to justify your role? We would love a nursing lead, but not sure that the trust will fund it. So we wish that there was a very simple answer to that question, but we know that there's not. And yes, it is extremely difficult in this financial time. It's about thinking about what the broader benefits are for the patient. So looking at the data that colleagues that are on this call that are in the network, I would like to start bringing that together and looking at what the benefits have been at different sites and how we develop that into something more robust that sites can use to try and convince people. So it's thinking about the length of stay, speeding up the front end of the pathway, as Guy has explained that he does, reducing them waiting times, facilitating the earlier discharges and bringing people back into clinics, as Amie's talked about, and then it's tapping into best practice tariffs, again, like Nick said. Thinking about patient feedback is always a really valuable thing to be able to include in business cases, because it's all about the patient's journey. So yeah, I think it's not one simple answer, but lots of different things that you can bring together to start to build up a convincing argument. But like I say, I would like to try and do that at a national level so that as NELA we can provide people with something as a starting point that they can use to convince the people who hold the purse strings. Guy, in terms of your role, where did the funding come from when you first started?
Hi, so I don't know the answer because, like I say, I'm from a trust where we had a very active and very involved NELA team. So I think they decided before I was in a post that they wanted somebody to take control of the database, make sure it's inputted, and I think they wanted a nurse, not quite sure where, but they wanted one. So the financing I can't comment on. I just know the finances from there's a best practice tariff. It's a lot of money. Nursing, NELA nurses, assure the data and achieve the best practice tariff. So there's a lump of money, but in terms of the contracts and how they work, I'm not sure.
But if we asked, sorry, I can't remember who asked the question, to email the NELA email, and maybe we could ask Guy if you could find out a bit more information, we'd be happy to share that through them channels. Nick, I know that you recently went through some financial negotiations. So in terms of money, how did that come about for you?
So my initial role was obviously introduced by the surgical team. And like I said in my presentation, by showing the evidence of data discrepancy and with the aim to get access to best practice tariff money was the card winner. Obviously, when you achieve best practice tariff, you get some money from NHS England, and it's not it's quite a lot of money because it's £900 per case. So if you do 300 cases per year at your trust, we are talking about £270,000 per year. So I'm pretty sure that will cover a NELA cost, at least.
Yeah.
But it's not only that. It has been demonstrated that, like Guy has said, by having someone on the roll, in time, it shows a difference. It reduces the length of stay because your patients are getting to theatre quicker. It reduces mortality because luckily with the NOLAP study now, the surgeons and anesthetic colleagues and critical care colleagues are thinking twice on operating on old and frail patients. So yeah, I think yeah, from my point of view, the finance was the money was coming from the surgical team.
Yeah. But like I said, I think as a nurse, an AHP network, we've got work to do in being able to support other trusts to implement these kinds of roles, and that's the kind of work that we would like to do over the next year or so. We've got a comment from Maggie Clark, who was mentioned at the beginning. She's fantastic, one of the elder nurses up in Scotland. She's interested, Amie and Glenn at Leeds, in accessing your MLAP booklet, looking for ideas and advice. So I'm sure we can link you up via the network for that. Thanks, Maggie. We have Jill Murphy from Belfast. Nick, would you be able to share the NELA frailty pilot planning to improve our perioperative consultant role with emergency surgery?
Of course. When I first started this, the first person I contacted was Kate Vardy, if I'm not wrong, from Leeds. I think it was the first NELA nurse in the country. And I had a surprise that she was not in post anymore. And I managed to meet Emily. And from talking to Emily, after a webinar, I managed to get in touch with you, Angeline. That's why we create these networks, to share our ideas and to share our work and to share how we can make it better. Because as you probably know, my aim is to make the wheel spin, not to invent the wheel.
So if Jill gets in touch via the NELA email address, and we can ask for you to share your field pilot planning work with her via that channel, is that okay? Here's a question for everybody. What happens overnight or when you're on leave? Who covers this role? Amie, you're so lucky at Leeds that you've got two of you. So you help pick some of the slack up, I assume, if one of you's on leave.
Yeah, so I mean, annual leave, I don't think myself and Glenn have been off at the same time. Luckily, we tend to work between each other and plan in advance. So I mean, it's a Monday to Friday service. So it's always covered Monday to Friday. In regards to out of hours overnight, we work really close with the surgical teams. So they're aware of the NELA pathway, and then we always attend the surgical meetings on a morning to pick these patients up who've come through A&E, come through SAU, who've been operated on overnight. So we always discuss that in the morning. And then Monday is a very busy day. We tend to do a lot of catching up with everybody and figuring out what's been going on over the weekend. We did, before I was in this role, just over a year ago, I think it were in discussion whether we want to start covering some weekends, but we've not quite got there yet, and I think there's probably going to be a bit of a delay on that with budgets all over. So
yeah. I see there's a comment in the Q&A from Ben Box. Guy, I assume that must be a colleague of yours. He's saying, Guy's post was a new post. The trust were persuaded that would be useful. He has easily paid for himself in terms of best practice tariff, but has made a huge difference both in terms of quality of care and data. There you go, put that on your appraisal. We've got a question from an anonymous attendee. Nick, I'm in the same position as you were previously. My role is currently secondment. I'm trying to prove to the trust that it's worth a permanent role. Are you okay to provide us with your contact details in case we need some help or clarification? Also to Guy and Amie. So I would say to you, please get in touch with us via the NELA email address. You are more than welcome to join us in our next network meeting, but of course, we're happy to link up via email as well. So do that. It's nela@rcoa.ac.uk, if I remember right. See the time with 2 minutes off 2 o'clock. So let's go with one last question and a comment from Maggie Clark, who says, to have a nursing voice involved in NELA care is essential. We couldn't agree more. Do you work closely with ERAS, as Amy's role sounds similar in terms of patient care, teaching, follow-up clinics?
I don't mind that, sorry, go on.
So yeah, we do. We have kind of a huge ERAS role over on upper GI and pancreas. So we do liaise between each other at times. But specifically for our NELA patients, it's the NELA coordinator and practitioner who get involved for their care.
Yeah. So following the principles of ERAS, but it's NELA.
Yeah, so following the principles of ERAS, but also that continuity of care of following up once they've been discharged and even seeing them pre-op as well.
Yeah. And for me, it's the psychological support as well that makes such a huge difference to this group of patients.
Absolutely, yeah.
Go on, Guy, let me invite you to.
Yeah, so I've not long found out that some trusts have these ERAS specialist nurses where they would perhaps see them in a pre-op clinic and follow them and do exactly what we've just. The role is so similar, just we're looking at it from an emergency surgery point of view and they're looking at an elective point of view, and there's lots of framework and things established already from an ERAS point of view. But now that there is ERAS emergency laparotomy guidelines in a 3-stage set, so in terms of enhancing practice and coordinating services, it's just following those principles, which is essentially what a nurse does. But yeah, if someone was an elective ERAS patient, for example, and they had a post-op complication and needed to go on to the emergency ERAS type of surgery, then I would go and introduce myself and say, I know you were in pre-op and you had these expectations of your recovery, but you've now come onto an emergency sort of pathway. But yeah, so a lot of ERAS.
Yeah, good nursing care, I say, good principles of good nursing care that all comes together. So there's loads of questions I wanted to ask as well that we've not got round to. So hopefully that means that we've got that we'll be able to arrange a session again in the future so that we can answer more questions, provide more information. But for now, thank you to all the attendees for joining us. I hope that found it useful, that it gave you some food for thought. If there's any follow-up questions that you think of, please do get in touch with us and we'll do our best to answer them. If there's anybody who would like to join our MDT network, absolutely get in touch. You are more than welcome to do that. And we'll see you again next time, hopefully. Thanks, everyone.